Namaskar and warm welcome to honorable doctors and thank you for joining us today. We are excited to present an overview of scientific sessions presented during recently concluded ADA. We look forward to an engaging and informative session. Doctors, I take this opportunity to present brief introduction of my company, Acumentis Healthcare Limited. Acumentis was founded in 2010 and is one of the fastest growing company in India. We are present in multiple therapeutic segments like gynecology, cardiodiabetic drugs, pediatric drugs, dermatology, ortho, and critical care. Acumentis is also known for launching innovative formulations. It has launched 18 formulations for the first time in India to its credit. We are currently ranked 59th in Indian pharma market and was awarded the Outstanding Corporate of the Year award in 2022. With this brief introduction, I request my colleague Altaf Kazi to introduce the esteemed panel and then take the program forward. Altaf, over to you.
Thank you so much, sir. Good evening. At the outset, I take utmost privilege in welcoming all of you to this prestigious and important ADA Connect initiative. I'm proud to say here that the objective of Acumentis, our company, and our division Noveltis and Novexa is to promote continuous learning in the ever-evolving space of diabetes endocrinology. I take utmost pride and privilege to welcome all the esteemed faculty and delegates to this important ADA Connect initiative. I'm indeed very thankful to Dr. Sanjay Kalra, Dr. Rakesh Sai, Dr. Shailaja Kale, and Dr. Antonio Cirillo for participating in this initiative as esteemed chairperson faculty. This special wrap-up session is a deliberation on recent advances in diabetes care and research drawn from the recently concluded ADA Congress. So therefore, let me first welcome Dr. Sanjay Kalra. Dr. Sanjay Kalra is a well-known endocrinologist from Karnal at Bharti Hospital. Dr. Kalra has been a past president for Endocrinology Society of India, has been a past president for South Asian Federation of Endocrinology Societies, has been a past president for Indian Professional Association for Transgender Health, and has been a chairperson educating working group International Society of Endocrinology. I welcome Dr. Rakesh Sahai. Dr. Rakesh Sahai has been a professor of endocrinology at Osmania Medical College and Hospital, consultant endocrinologist at Sahai's Endocrinology and Diabetes Center. Dr. Sahai is current president, Research Society for Diabetes in India, that is 2024. Is president for South Asian Federation of Endocrinology Societies. Dr. Sahai is immediate past president for Endocrinology Society of India. He's got many awards. One of the important award, Fellowship of National Academy of Medical Science in 2021. Dr. Rakesh Sahai has over 180 publications in various national and international journals. I welcome Dr. Shailaja Kade. She is a leading diabetologist from Pune, has been a professor in internal medicine and consultant diabetes unit in King Edward Memorial Hospital, Pune. She is the director to SKDC Diabetes and Specialty Clinics. She is the director for Orange Diabetes Medical Foundation Research Center. She has got numerous awards. For some of the recent ones is Surya Datta Sri Shakti Rashtriya Puraskar 2023. And she has been recently facilitated at Trinity College, Dublin, at Tricentenary Year Diabetes Program. She has co-authored many books in diabetes as well. I welcome our esteemed faculty, Professor Antonio Cirillo. He is head of diabetes department at RCCS, Multimedica Milan, Italy. He is the president of European Society of Diabetes for study group, especially on diabetes and cardiovascular diseases. Dr. Professor has published over 450 original papers. So now I hand over the forum to our esteemed faculty from India and request Dr. Cirillo to present a talk on recent advances in diabetes care and research. Thank you.
Thank you very much for the kind invitation. And sorry, I'm trying to share my screen. It's always really a pleasure to be involved in activities in in India, where I had the opportunity to be very often. I'm sharing, so my slides are okay, correct? Because I do not, okay.
Yes,
So
it's fine.
Perfect, sir. Perfect. We can hear you.
And in this occasion, we were told how the sponsor is widely involved in updating in the news about diabetes management. So it's really the right opportunity to share with you what emerged at the recent ADA meeting, which was held in Orlando, Florida, in the United States. There are really some interesting and important news which can have a clinical impact on the management of diabetes. First of all, very good news for retinopathy. You know, until now, any drug tested for the prevention of retinopathy in diabetes almost failed. Okay, we have honestly very good opportunity because if we follow the people with diabetes, we have the opportunity to use the laser or in advanced situation also the injection of some drugs to prevent macular edema. But this study presented at the ADA is really very, very important. First of all, because has been supported by the NIH, which means that was an independent trial supported by the National Institute of Health of the United States, and then means that is a real independent. And also you can understand why a cheap drug like fenofibrate, which probably would have been not tested by any company, has been instead tested by a national institute. And the design of the study was very interesting because it was comparing the effect of fenofibrate, 145 milligrams, to placebo in to very important first primary outcome. Because you see that the primary outcome was the time to first occurrence of referable diabetic retinopathy or maculopathy, treatment for diabetic retinopathy or maculopathy, laser intravitreal injection, vitrectomy. So very hard at the point. You know that the fibrate is used for mainly to reduce triglyceride. In terms of cardiovascular protection, any trial with the fibrates, any kind of fibrates was quite disappointing. But now we have this interesting news. And the trials, the follow-up of 5 or 4 years or until the have elapses, then the median of randomized people were having an event. So this is the result. You see highly significant protection of the fenofibrate against the risk of developing or worsening retinopathy. This is very important news because you know very cheap drug can be used to prevent retinopathy in people with diabetes. And until now, in terms of pharmacological treatment, we were having almost nothing. And the only good approach was good glycemic control. The summary of the LENS trial was that in participants with early diabetic retinopathy or maculopathy, treatment with the fenofibrate reduced progression to referable eye disease or treatment thereof. Benefit of treatment appeared similar in various pre-specified group of participants. We also observed reduction in any progression of retinopathy and macular edema, benefit quantitatively similar to hypothesis-generating results from cardiovascular trials. Methodology demonstrated how large retinal screening programs can be used to conduct randomized trials. So this is also really important to have early screening, not now, even more now, in order to identify people at high risk for retinopathy, having a new tool to prevent retinopathy. But also in terms of retinopathy protection, we have also good news regarding a class or a new these new drugs that are the SGLT2 inhibitors. You know that these drugs, which have been demonstrated, we see also some data later more specific, but you know they are demonstrated to be very helpful in preventing cardiovascular disease, particularly heart failure, but also in protecting the kidney, but never have been tested specifically for the possible benefit on the retinopathy. And you see here that pre-administration of SGLT2 inhibitor reduce the frequency of anti-VEGF agent administration in patients with mild diabetic macular edema. So this really is a new proof for SGLT2 for a new action, which was supposed but not yet demonstrated in terms of retina protection. And you see here that this was this trial an SGLT2 which is not commonly used, because the study has been performed in Japan, but I believe that this could be a class effect, was comparing the effect of leucogliflozin with the control group who was treated with glimepiride. And after this period of the observation, you see the effect on the injection and an anti-VEGF needed to cure the macular edema. You see that there was a huge delay in the need to use this kind of drug. So again, in terms of conclusions, we can say that the bilateral anti-VEGF therapy and fellow eyes, the effectiveness of a bilateral anti-VEGF therapy in reducing the total number of injections likely primarily reflects treatment effect on the fellow eyes. Reducing fellow eyes eye injection suggests SGLT2 inhibitor potential efficacy in mild early stage of the diabetic retinopathy, mild retinal, and possibly preventing new onset of cases. In terms of adverse events were similar between groups, indicating that combining SGLT2 inhibitor with anti-IGF therapy may ease the treatment burden for people with diabetes. In conclusion, this study represents a groundbreaking milestone as the first intervention trial examining the efficacy of an SGLT2 inhibitor for treating the problem of the retinopathy. And this finding suggests that SGLT2 therapy could serve as a novel, non-invasive, and cost-effective treatment option for some patients with diabetic macular edema. So, which is really a dramatic situation, because very often people with macular edema they lose the possibility to the vision. So this is very important news, meaning that when we had an SGLT2 therapy, we also protected the eye, not only the kidney, not only the heart, but also we have evidence now for the eyes. Then let's move to another SGLT2 effect regarding the coronary flow reserve increase after dapagliflozin treatment in patients with type 2 diabetes, which in this study is shown to be maintained after 4 years. And this is a 4-year health follow-up study. And again, it's really interesting because you see that the dapagliflozin 10 milligram was compared to the placebo, and some characteristic, particularly the blood flow, was evaluated. And you see here that there was a 30% increase in coronary flow reserve, which was maintained after 4 years. This is quite interesting because it shows that the effect of DAPA, but again, probably we can speak about class effect, is the effect is lasting. It is not lost after short time of the treatment, which sometimes happens for other drugs. And also about the hypothesis about how this can happen, that in the study it has been advanced that probably the treatment with dapagliflozin in type 2 diabetes with a stable coronary artery disease, reducing the thickness by 30%, as well the glucose uptake, increasing the uptake by 21%. So this can really improve the coronary flow and keep the increasing coronary flow for long term. So the take-home message was that this 4-year follow-up study demonstrates that 30% increase in coronary flow reserve obtained after 4 weeks of treatment with dapagliflozin is maintained after 4 years. This data also confirmed the placebo group validated the previous published result in a new population. And the increase in coronary flow reserve could depend on the reduction of the thickness and inflammation of the membrane determined by SGLT2 treatment. This improvement could have important implications on the management and prognosis of patients with type 2 diabetes and coronary heart disease. So 4-year keeping for 4 years the effect is really a very important evidence. And okay, what happened now? Now we also have some news regarding a new drug, which is already available in some countries, will be very soon available also in Europe. It's already available in the United States, as well in Canada, as well in the Middle East. And the background of this study is that, you know, tirzepatide is a once-weekly glucose-dependent insulinotropic polypeptide. It is a molecule in which are merging a GLP-1 receptor agonist and a GIP. And in the Solomon 2-3 trial of adults with overweight, obesity, and type 2, that tirzepatide significantly reduced body weight beyond a reduced calorie diet and increased the physical activity. So we know that now the company is claiming that the tirzepatide is a stronger drug available for weight reduction, even more than others. And in the post-hoc analysis of the data from Solomon 2, we're assessing the proportion of participants achieving a triple endpoint composite of goal for blood pressure, lipids, and glycemia. Because, of course, the main goal is to reduce weight, but do not forget that tirzepatide was more to control glycemia for diabetes management. And glycemic improvement of glycemia is an important target for this drug, but of course, as any GLP-1 analogs, also it has some effect on blood pressure and lipids. And in this post-hoc analysis of trial, it has been observed that with the tirzepatide at 10 and 15 milligrams were associated with a larger number of patients achieving the triple endpoints compared to placebo. So at the same time, they were able to keep the improvement in lipids, A1C, and blood pressure using tirzepatide. And this was as for other GLP-1 molecules, even tirzepatide is not really a GLP-1 because again, I would remember you that is the connection in one molecule of GLP-1 and GIP. So it cannot be considered GLP-1 really, but similarly to many others GLP-1, the effect was independent from body weight and from body weight at the baseline. So it works and keeps the effect on lipids, blood pressure, and glycemia at any level of body mass index. And then this post-hoc analysis of the SURMOUNT-2 trial participants with type 2 diabetes and overweight obese, more participants receiving tirzepatide achieved the triple endpoint of blood pressure less than 180 millimeters of mercury, non-HDL cholesterol less than 130 milligrams deciliters, and A1C less than 7%, 6%, or 5.7% versus placebo, regardless of tirzepatide dose and baseline BMI. Among those receiving tirzepatide 10 and 15 milligrams, more than 80%, 27% to 99% achieved the triple points, which of A1C less than 5.7%, 6.9%, and 7% respectively. And regardless of baseline EMR category, more than 23% achieved the triple endpoint with an A1C less than 7%. So very, very important endpoints. This suggests that in addition to meaningful weight loss, tirzepatide might be associated with achievement of blood pressure, non-HDL cholesterol, and A1C goals in people with obesity and type 2 diabetes. I want to underline that the effect on HDL cholesterol is not so often. Many drugs were failing to show an effect in improving HDL cholesterol. But in this case, probably there is the benefit and not a problem. And let's move to the SURMOUNT OS8. You know, in the last years, or let's say the last couple of years, semaglutide have received a lot of claim, probably is the star of the obese treatment. But this is something different because this case in the using tirzepatide, you see here the effect of something that until now has been not explored so much, and meaning the function at the pulmonary level. And you see is how it is really improved dramatically. And it keeps after 42 weeks, and there is a huge improvement over this situation. So in the conclusion, tirzepatide demonstrated superior clinically meaningful improvement of sleep disorders breathing compared to placebo. Tirzepatide demonstrated superior improvement of sleep-related function and quality of sleep compared to placebo. Tirzepatide demonstrated superior improvement of severe risk factors. All type 1 error controlled key secondary endpoints were met in both studies for both efficacy and treatment regimens estimates. So I think that not going more in details, this is something very interesting because, you know, the sleep disorders and the associated problem in terms of breathing are also emerging as a key comorbidity, particularly in people with diabetes and obesity. And it's very difficult, and it's not enough just to control the weight. Even this is, of course, is helpful. In this case, you improve with hepatitis the profile of cardiovascular risk factor, but also at the same time, reducing the weight, you improve the sleep and then also the breathing during the sleep. Something new in the scenario of diabetes treatment. The safety and tolerability profile of tirzepatide in people with moderate to severe sleep apnea and obesity was generally consistent with the safety profile of tirzepatide and incretin-based therapies in people with obesity. The most frequent adverse events were gastrointestinal related and were generally mild to moderate. Gastrointestinal adverse events were more frequent earlier in the study. As usual, in time, many of these side effects are lost and people can continue. There were two positively adjudicated cases of acute pancreatitis, both were tirzepatide-treated patients. Unfortunately, we know that this can happen, but until now, the ratio between the cost benefit, the risk benefit of treating somebody with a GLP-1 analogs is superior to the risk of having particularly the pancreatitis. Which are the key messages of this study? The tirzepatides demonstrated superior and clinically meaningful improvement of sleep apnea-related disorders like breathing. Tirzepatide demonstrated superior improvement of patients' reported quality of sleep and sleep-related functioning. Treatment with tirzepatide translated to clinically meaningful improvement in sleep apnea and obesity-related cardiovascular risk factors. The safety and tolerability profile of tirzepatide in people with moderate to severe sleep apnea and obesity was generally consistent with the safety profile of tirzepatide and incretin-based therapies in people with obesity. This is also again something new. This is the sleep disorders and also the breathing disorders never have been touched in any trial at the moment. And now we have good news. And also we have another interesting post-hoc analysis related to tirzepatide, related the effect of tirzepatide on the kidney. Is again a post-hoc analysis of the SURMOUNT-2 trial. You know, the objective of the study was to compare tirzepatide 10 and 50 milligrams to placebo, and the eligible criteria were having a body mass index, which was not very high, you know, 27 kilogram meters per meters, like, and so a glycated hemoglobin between 7 and 10%. So this is a group of subjects which is not really very, very obese. And in this, I would remember that in the SURMOUNT-2 trial, the tirzepatide, particularly 50 milligram, reduced mean body weight, A1C, and systolic and diastolic blood pressure. But no data were evaluated at that time on the kidney function. And you see that again, we have some good news because the decline between tirzepatide and placebo were comparable between placebo and tirzepatide, but there was an interesting effect on albuminuria. And so this means that we have a protective effect on the kidney using tirzepatide. Even the GFR was not different by using placebo, but the so strong effect on albuminuria is, of course, very, very relevant. So in summary, in this post-hoc analysis, and please pay attention. This is a post-hoc analysis. So the study was not planned to see the effect on the kidney. So it was not planned to have, for example, the number of people needed also to observe the effect on GFR. And anyhow, we got interesting results on the possible effect of the tirzepatide in protecting, in improving the albuminuria. So more clinical trials are needed, and I think that they will be done. But in terms of GLP-1 and the kidney, we have now the FLOW kidney outcome trial. This trial was first presented at the European Renal Association meeting in Stockholm last few months ago and published in the journal Medicine. But of course, when the authors were submitting the study at the ADA, the study was not yet published. But this is very interesting because the trial was planned to show an effect or not of semaglutide on kidney function. And you see that it works, meaning that there is a huge impact on the improvement of a composite kidney outcome using semaglutide. And you see that it works almost on any kind of kidney complications. Of course, the primary outcome is a composite, because if you want enough number, you need to have a composite outcome. But if you go more in details, you see that in any case, even in terms of kidney failure, initiation of chronic kidney replacement therapy, onset of persistent GFR reduction less than 15 milliliters, onset of a persistent more than 50% reduction of GFR, the data are going in the right direction. Even there is not a superiority for each of them or for all of them, but anyhow, all are going in the direction of an improvement. And when you pull all this data, the final effect, very clear, is that there is a positive effect in protecting the kidney, which, interestingly enough, is accompanied by a significant reduction of cardiovascular death. And you see here, more in details, the change in GFR using semaglutide or placebo, and there is no doubt that semaglutide works in protecting the kidney. So at the end, the results of the FLOW trial were that there was a 24 lower risk of the composite primary outcome, consistent risk reduction for kidney disease components of the primary outcome, consistent risk reduction across pre-specified participant subgroups, slower reduction of kidney function by a mean of GFR of 1.16 milliliters mean, milliliter minute, or the 73 meters square year. And over 3 years, 20 people would need to be treated to prevent one primary outcome. So it's a good price to pay. But the FLOW trial was reported also another aspect in terms of CV outcome at the ADA. And again, you see that in terms of outcome, cardiovascular outcome, also the results are very interesting because the cardiovascular disease, meaning an effect on cerebrovascular death, non-fatal myocardial infarction, non-fatal stroke, which are the three components of the MACE, which FDA requires, but in this study, this was a secondary outcome, was confirmed. Because, semaglutide already showed an effect on this MACE, but also this was confirmed in the FLOW trial. And also here, you see that my main effect was on cardiovascular death. And as in already reported in other trials with the GLP-1, there is no, apparently, there is no benefit on stroke. And when you look specifically at the most powerful outcome, you see that all-cause death is really the stronger outcome, which is reached by using semaglutide. And when it goes to when we see at the hierarchical testing strategy, because this is the approach for the evaluation of a trial, specific trial, you see that the first composite kidney outcome was reached by the trial. The total jet stroke was also accomplished. MACE, CV death, non-fatal myocardial infarction, non-fatal stroke was also achieved. All-cause death was achieved. So clearly, also it is an important statistical approach to confirm the validity of the data of the trial. This was confirmed in the FLOW trial. So in conclusion, there was, in terms of cardiovascular risk, a 20% lower risk for overall death and 80% lower risk for CV death, non-fatal myocardial infarction, non-fatal stroke. 18% is what usually you reach also using other approaches. And I think also this is a pragmatic trial comparing semaglutide in type 2 diabetes. And you see here that this separate study design was to compare once weekly semaglutide in alternative semaglutide with any anti-diabetic drug excluding semaglutide. And this was used in people needed for treatment intensification. And you see here that there was a significant reduction in the A1C, so meaning that the semaglutide was very powerful in further improving glycemic control. And all participants receiving alternative treatment at year 2, 37.4% were not receiving the treatment selected for intensification. So semaglutide avoiding the need for further intensification. So in conclusion, semaglutide is a more effective treatment option compared with alternative treatment at achieving and maintaining glycemic control in adults and not well control in the routine clinical practice. Adults who added semaglutide to their treatment regimen showed a numerically greater absolute reduction in body weight at 2 years compared with those on alternative treatment. Fewer adults in semaglutide group required further treatment intensification compared with the alternative treatment group. Titration to higher dose antidiabetic drugs was limited in this setting. No new safety concern. So findings from separate trial demonstrated that once weekly semaglutide provides effective and durable treatment intensification in the real-world clinical practice. And now let's move to a couple of very interesting studies. First of all, related to use of glucose monitoring. What happens in terms of A1C change after initiating continuous glucose monitoring in this setting of a large US managed healthcare plan? And you see that this is a retrospective observational study, and the outcome were a change in A1C, diabetes-related complication, and it was used in type 1, type 2 intensive insulin therapy, or any kind of insulin therapy. And it's really interesting that the change in the A1C was very important in people who were using CGM, particularly. So this means is in this kind of setting. Again, this has been also was accompanied by the appearance of diabetes complications. So meaning that the CGM impacts on glycemic control, and this is accompanied by an improvement in the number of complications. But this is the last study I present. It is something very new, but probably in which now we are working. How CGM can be also a very good educational tool in type 2 diabetes, which are not, who are not taking insulin. And this is because we, at least many of us are using this already, but this is a trial, so it's a study, it's not a personal experience. So it was a randomized two-arm prospective study, and the aim was to evaluate the impact of addressing self-management, the change in food and other behaviors of glucose time in range in people with type 2 diabetes, not on insulin, using the Freestyle Libre system alone or in conjunction with the food logging application. And the idea is to how much we can improve or we can have a better time in range. And you see here, it works as educational tool to know what happens when you do some daily activities like mainly eating and then adjusting the diet can really improve, dramatically improve the control, particularly increase the time in range of people who are using CGM. And again, it is keeping after 3 months, there was a more than a 1% reduction in A1C. So I think that is a proof that just using a CGM as an educational tool is very important. In terms, you see that almost all the measures, all the metrics of a time range were affected and improved. So this is also important because also there was an effect on glucose variability, which is different by the concept of just the time in range. So in conclusion, people with type 2 diabetes not using insulin and without medication changes show large clinically significant improvement in CGM metrics and A1C when using either CGM alone or CGM plus a food logging application. So it's an application which is helping in choosing the right food. This is an important news because people with diabetes can be helped knowing what happens when they are eating different food, just adjusting the diet in improving their glycemic control in any aspect of glycemic control. So thank you very much. This was the last study I presented.
Thank you so much, Dr. Antonio. Wonderful and a very comprehensive yet crisp coverage of what was discussed at ADA. Just to paraphrase what Dr. Antonio has discussed with us, we can perhaps structure his talk into 4 verticals. The first vertical, he has actually been able to thread the eye of the needle. We always tend to speak about the bigger glands, the bigger organs, the heart, the kidney. We forget the retina, without which none of us would be able to attend this webinar. And he's talked about how you can use fenofibrate or lucioglyphlosin for secondary and tertiary prevention of retinopathy. So thanks, Dr. Antonio, for highlighting that. Not only has he been able to thread the eye of the needle, he has also been able to touch the heart of the matter. And that is with the research on coronary flow reserve and dapagliflozin. So we keep on uncovering newer and newer aspects about SGLT2 inhibitors. Now, my knowledge of American political history is not all that good, but I know their motto. It says in Latin, out of many, one. So that is the motto of the American founding fathers, plurabilis or something. So Latin is not my cup of tea, Dr. Antonio. You must have realized by now. But out of many, one is actually what tirzepatide and semaglutide do. So all the many diseases, whether it's renal or obstructive sleep apnea related, or cardiac or glycemic or body weight related, you're able to use one drug to handle many diseases. And that is the data that Dr. Antonio has shared from regards to tirzepatide and semaglutide. If there is one definition of holistic care that the person would want, when you speak of person-centric care, the person would want, give me one drug and take care of everything for me. So hopefully we are able to, we may be able to achieve that in the near future. So these were three verticals about retinopathy, about cardiac disease, about holistic care, or out of one many, that's tirzepatide, semaglutide. The fourth vertical is monitoring. And Dr. Antonio has been able to show that continuous glucose monitoring is not just a diagnostic tool. It is a theranostic tool. He used the word educational tool. So it's theranostic because it helps you diagnose glucose levels. And it also helps you from a therapeutic perspective. The patient himself or herself is able to make changes which lead to therapeutic outcomes. So thanks, Dr. Antonio. We have Professor Rakesh with us. Dr. Sahai serves as president of our National Diabetes Association of the South Asian Endocrine Association, and he is also president of the National Diabetes in Pregnancy Study Group. And one thing that Dr. Sahai shares with you is the passion for controlling postprandial glucose. So to put in perspective, Dr. Antonio, all the evidence that you've given us over the past couple of decades, that we have learned from a person called Professor B.K. Sahai, who happens to be Professor Sahai's father. And that is what he used to teach us many years ago, that don't focus on fasting alone, focus on postprandial as well. And you would really enjoy, sitting with senior Professor Sahai and learning from him, his insights. But Dr. Sahai, your comments on today's talk, please.
Yeah, I think it was very comprehensive. Dr. Antonio took us through the entire, what do you call, summary of what was discussed in the ADA. And he brought out, as you very rightly put it, in the four verticals, the effects on the eye, the effects on the heart, and then we saw the multifaceted effects of tirzepatide or even semaglutide for that matter. And the way we have seen in the real world study that the adherence to semaglutide is much better than any of the other options that we have. And these, I think, are really useful insights that we've learned. And the finally, the one about CGM is really helpful in understanding that CGM goes beyond diagnosis itself, but diagnosis of the glucose variation, glycemic variations, but also helping in changing behavior of the patient. If not, if not just giving them changing their diet, but also changing the behavior over a period of time. This is going to actually make a huge impact in terms of the behavior of the patient, in terms of their food seeking behavior, and that's going to really make a long-term difference, because this was a study which looked at the short-term outcome in terms of the eating behavior. But I think when you follow them up, I think this is going to be having a far-reaching effect.
Dr. Antonio, a question coming from the audience is, in the average European individual living with diabetes, what is the perception of retinopathy? Is it perceived to be a complication that is as serious, as deadly as heart disease or kidney disease? Or is there a kind of a bias against eye complications?
I have to say that until the situation is really seriously damaged, in terms that they are maybe going to have macular edema, because at the end, honestly, in Europe, because we have advanced screening programs and so on, only few people are getting blinded for retinopathy. But the problem of macular edema is something else, because you cannot really well control. So they only at this stage, the perception is that also retinopathy is important. Because on the other hand, I think that also is our fault. Now we claim for cardiovascular, kidney disease, and almost we forget that retinopathy, and I have to say neuropathy particularly, also are very serious complications and not well treated, meaning that until now, what were we doing for retinopathy? We were following, and if something was happening, go to the ophthalmologist to be treated. Now, I think also the approach of endocrinologists can change, and we have to understand if we have, for example, we can start because of phenofibrate very early, because anyhow, very often you also have a hypertriglyceridemia in our patient. So why do not use a fibrate for to take off the lipids and the triglyceride in particular, and also to protect retina. So this is a new paradigm that probably we need to implement in the clinical practice.
Thanks. Dr. Rakesh, your comments on this retinopathy and the level of seriousness that the community takes, and any best practices you've been trying to sort of create in our great country.
Yeah, I think as Dr. We tend to have a little problem in terms of picking up retinopathy because this is a problem that is not recognized easily. And now I think there is a change in the last few years with the availability of the handheld fundus cameras, and we're able to screen more and more of our patients and refer them. So but still, what happens is that what we see is that practically, although we screen, the patients don't realize, and we identify the presence of background retinopathy or maybe pre-proliferative retinopathy. Patients don't realize the importance of that. They don't go to the ophthalmologist. So we are trying to study a pathway of having a better referral, where we have a better communication with the ophthalmologist. That is what we are working on, and I think we are doing a study which is funded by the ICMR, and we're looking at how to improve these referral pathways.
Thanks. There are more questions, Dr. Antonio. You've talked about dapagliflozin and its effect on coronary blood reserve, flow reserve. We are also aware of the various pleiotropic benefits of SGLT2 inhibitors. The direct question is, would you recommend using an SGLT2 inhibitor as first-line therapy in a person who is newly detected to have diabetes?
Absolutely. Absolutely. Also, I have to underline that now we have got this new interesting data, but maybe I was personally publishing in Lancet that an early introduction of an SGLT2 can prevent the metabolic memory, the so-called legacy effect of hyperglycemia. So it's clear that as soon as you introduce an SGLT2 in the therapy, dapagliflozin or what we want, but better could be the outcome in terms of prevent complications.
Dr. Sahai, your comments. In India, can we use SGLT2 inhibitors as monotherapy, or would we use along with metformin? What would your suggestion be?
Yeah, I think
the question is newly diagnosed diabetes.
Yeah, I think then again it depends on the background of the patient. There are many who have pre-existing cardiovascular disease, and those who have got all the risk factors for cardiovascular disease. In them, I think there is a very strong indication for using SGLT2 inhibitor. Whether you add metformin or not, that depends on the glycemic status of the individual. If the glycemic status does not warrant much of medication, then I think we would just go with SGLT2 inhibitor, and also again the tolerability of metformin is that issue. So I think it is an important molecule to be used right at the onset of diabetes in many situations.
Thank you. Dr. Antonio, more questions coming up. You also shared data about tirzepatide and semaglutide. So question is, a real world experience of tirzepatide. What experience do you have in Europe?
In Europe is not so much because, tirzepatide was available, approved, but the company preferred to not risk the shortage of the other company, meaning that they didn't launch at all tirzepatide in Europe. Probably will be launched at the end of this year, because the problem was what happens to the others also teach you what you have to avoid. This is something that in the life happens for any aspect. And the company producing tirzepatide, they prefer to be present only in the States, even having already the approval in Europe. because they were unable to produce enough, and in order to avoid the problem of shortage, which is really a problem, because the EMA, which is the European medical body for the control, now is raising the problem for the shortage of semaglutide, because when you stop, this is really a problem. I have accepted to be published. I'm editor of the RCP, the IVF journal, and we received some reports from different countries. And particularly from Australia, they reported a very well focused report, and the shortage of semaglutide was accompanied by a really dramatic situation in terms of weight regain, A1C increase, and so on, which of course is not good at all. So it is.
Thanks. Dr. Sahai, so that was an international perspective. Indian perspective, patients in Hyderabad coming back from UAE, bringing tirzepatide with them and bringing semaglutide with them. Patients in India getting it from the black market, the gray market, the white market.
Well,
Your comments.
very limited experience on that. So, I mean, I won't be able to comment much on that because very limited experience and very few patients who are doing that, and maybe just a little bit of experience on the clinical trials.
So clinical trial data is actually very impressive and very, it creates an optimistic view actually about being able to manage diabetes and obesity as we go forward. The only challenge, I guess, Dr. Antonio will agree, the diabetes pandemic or the metabolic syndrome pandemic seems to be faster than we are. So the pandemic is growing faster than our colleagues in the pharmaceutical world. And the pharmaceutical world is actually doing a better job than us in clinical practice because it takes time for us to translate the developments into clinical care.
Yes,
how can we improve this, Dr. Antonio? How can we become faster, stronger?
Reducing the new cases of diabetes. There is no chance. I'm sorry for the pharma companies, because anyhow, the market will be there, but the only chance is to reduce the cases of diabetes. We will never be able to run against new cases, more cases, so on. Also, I want to raise an issue about the GLP-1 classes. Now, an issue in terms that an example is the shortage, but is just giving an idea what happens when you stop. And in my opinion, the GLP-1 should be stopped at some time. You cannot continue forever. You have a young obese patient. How long you can treat? For the life? I don't think so, honestly. And at the moment, all the data are showing that when you stop, there is a gain of the weight, the worsening of the glycemic control. So we need a new strategy for use of these drugs.
We have people logged in from across the country. Dr. Aditya KNV, who is a dynamic physician in Chennai. You had just taken his question. We also have Dr. Kumar Bhandari from Gangtok in Sikkim, in Eastern India, one of our most beautiful states. And then Dr. Kaushik Roy from Hazaribagh in Jharkhand. That is, I guess, one of the most beautiful parts of the country, Jharkhand state and Chota Nagpur Plateau, where Dr. Kaushik is from. There's one more question that they have for you. Glimepiride and metformin. We listen to lots of debates in international meetings, but then the debater is there because he or she has a point to prove. So let's speak in the spirit of person-centered care. Glimepiride, metformin, do they have a role today? Will they have a role tomorrow in clinical practice?
So I believe metformin has a role, because it can be the background of almost any kind of combination. And my personal view is that the combination should be used as soon as possible, because it's well known, my position is that you have to take all different targets. There are at least 8. One drug would be not enough. So metformin is there. About the sulfonylureas in general, I think that, of course, there is less need to use them having other drugs. but does not mean that you do able to cancel for the portfolio, because anyhow, going ahead, there will be the problem of beta cell exhaustion, and or you start insulin. And I believe in this case also GLP-1 cannot work, because anyhow GLP-1 needs beta function in beta cells, otherwise there is no insulin in any case. So the sulfonylureas can be let's say, considered in a very late stage of the disease, whether there is no insulin, not any it's difficult to get the control. You have a patients very reluctant to have insulin, so a period of sulfonylureas is reasonable until occurs you probably you will need the insulin. But it is a setting, in my opinion, sulfonylureas is still a role.
We are aware of the British guidelines, the American guidelines, and the global IDF guidelines as well. And you focused on postprandial glucose. But there must be guidelines in Spanish language and French language, which we are not able to access in India. What do those guidelines say, sir?
Oh, okay. The terms of PPG is there, because I'm very proud that this story of PPG is now in all the kind of guidelines. There is no guidelines which forgets the need to use control PPG. And of course, you have different targets, which is quite strange, because you have different targets, different time frame. But anyhow, the recommendation is there. I think that shortly, when the CGM will be more and more and more available, because in my opinion, this will be more cheaper in the future, because more use, cheaper will be. You will see that the postprandial is just a part of a more complex story of glucose fluctuation in a day. At that time, was CGM was when we were working on PPG, CGM was not available by the beginning, and now it's clear that the PPG is a part of a more complex aspect of glycemic control. And at least to control PPG is not difficult, because now you can measure, you see, and then you can control with diet, particularly changing the diet or with the drugs. But it's in all the guidelines, including the Chinese guidelines, if you are interested.
Dr. Sahai, your comments on guidelines from India, evolution over the past few years, and how different are they from Western guidelines? How similar are they to guidelines from Europe and from US?
Yeah, I think, if you look at our own guidelines from the RSSDI and even the Endocrine Society of India, we have been having these guidelines, several editions of these guidelines. And although they were derived initially from the IDF guideline, but a lot of Indian perspective was added to that, particularly when you come to therapeutic areas, particularly the choice of therapies. A lot of Indian perspective was added to that, and I think the importance of postprandial hyperglycemia was highlighted in our guidelines, and also the need for use of sulfonylureas, particularly the importance of using them initially, because there's a large subset of our patients who are lean and with type 2 diabetes, and who benefit more from the use of sulfonylureas as compared to metformin. And so that aspect was also highlighted in our guidelines.
Thanks a lot. One other difference we have, Dr. Antonio, of course, the Indian psyche is quite similar to that of Italians. The same good things, the same bad things. The food also is similar. The names are different. So what you would call a pizza, maybe we would call it a paratha or a chapati, but it's all bread-based and it's all cereal-based. So everything is similar. One difference is that we have a higher quotient of spirituality here. So our guidelines tend to expand upon the psychosocial aspects of diabetes care. As an example, we would speak about yoga, and we would also speak about an Islamic practice called muraqabah. Muraqabah is the loose translation would be meditation. The exact translation would be religious or or spiritual meditation. And that is something that Professor Rakesh Sai uses in his clinic. So, for example, a type 1 girl who is struggling with lack of self-discipline, or a type 2 person who says, or someone with obesity who says, sir, I'm very fine. I want to follow everything that you're telling me to. But from 8 p.m. to 11 p.m., I just cannot resist eating my pizzas. So what do you do at 7:55? You do a 3-minute episode, 3-minute sort of practice of muraqabah, which is religious meditation, being in touch with God, and that gives you the self-discipline to continue for the next 3 hours. So these are things that we are working on in our guidelines. The only challenge is that we are quite good at experience at speaking, as you've seen. We are not all that good at collating our evidence because, to be honest, we don't have the manpower. So there are a million things going on and we just kind of forget to document. So that, of course, is our fault. Perhaps Dr. Rakesh, I will now take it upon his shoulders to make sure we overcome that before next year's ADA.
I have seen some papers on this effect of yoga and so on. I think also we have accepted some papers, and it's not surprising. In the Western society, we use psychotherapy, which is almost equivalent, and I think it's more difficult than a religious approach, because the trust in a God, I don't want to go in the fields, of course, I'm not an expert, but if you have a trust in God, any kind of God, we are not discussing this, you are more prone to follow the advice or to do something. Psychotherapy needs more time because it deals towards the subconscious level and so on. But in both realities, Western or Indian, I think that this is very important. On the other hand, it's a very common experience that the situation of stress is worsening diabetes. So you can get an improvement just simply reducing the stress of the person. This is a practical experience that also I can share. That if you are able to reduce the stress, also glycemia is better controlled.
Point well taken. With this, I'd like to thank both Professor Sahai and Professor Antonio. It's been great. Our aim for today was to learn about what happened during ADA last month. And within 1 hour, our experts have been able to actually take us through that journey in a very beautiful, in a very meaningful manner. We have Mr. Altaf Kazi with us as well. So a question to you, Mr. Kazi, which is, I'll speak in Hindi and then in English.
Yes,
तो
sir.
मंजिलें अपनी जगह,
जी,
रास्ते अपनी जगह, और
जी,
हमसफर अपनी जगह. The
जी.
destination has its own charm, Dr. Antonio, but then so does the journey. And what about the companion, the journey companion, the co-traveler? So the question to Mr. Kazi is, which of these is the most important, Mr. Kazi?
So very difficult to answer that, but I like the way you put up the. So I think for us, journey is more important. I mean, if I were to take anything from this important session, is that you've given a lot of perspective. I'm sure many of our delegates. I think I must before I thank, I must tell you that on this important day, there are about 972 delegates who have joined this meet here. So that shows a lot of interest in what you mentioned about it's a continuous journey on the various understanding of diabetes and discovering as you said that we are not able to catch up with the pharmaceutical is giving a lot of molecules, but at the same time disease also catching up big time. So I think it's a long journey for us, sir.
Right. So
Yeah.
thank you.
Yeah,
Any
so
comments, Dr.
yes.
Antonio, before we?
No, I think that this is something that at the IDF level, unfortunately, you know what happened recently with the president, with the dear actor,
You passed away.
the president. The idea is that we need a very strong alliance with all the actors, because we need the alliance between the health bodies, patients, and pharma companies. We cannot forget that the pharma companies are our allies, are not something different. I'm speaking particularly for Western the Western societies, Western culture. So all together, only working all together, we can improve the situation. Otherwise, it will be very, very difficult to win this very tough fight with diabetes.
This is something that actually finds resonance in Charak Samhita, in one of our oldest books, the book of Ayurveda. So in that, Lord Atreya talks about Atreya's quadruple. And Dr. Rakesh is an expert on that. So what Atreya says is that all 4 members of the team have to be equally competent. The person living with diabetes, the physician, the attendant or caregiver or diabetes educator, and also the drug and the people who make the drugs for us.
Exactly.
Absolutely. Very true.
So if one
And,
by one,
and,
Dr. Sahai and then
and,
team.
and we enjoyed, as you said, we not only on the journey, but also companionship. We enjoyed the companionship today.
Dr. Antonio. So thanks for being our thanks for being our humsafar. So that's a new Urdu word that we would leave Dr. Antonio with.
Thank you, sir.
Thank you for joining us in this journey and making our journey meaningful.
Okay. Have a good evening. Ciao.
Thank you.
Sir, on behalf of Acumentis and our divisions, Noveltis and Novexa, I would like to thank all esteemed faculties for participating in this AD Connect program. I express my sincere gratitude to Dr. Sanjay Kalra, Dr. Rakesh Sai, Dr. Antonio Chilore for joining this program. My heartfelt thanks to each and every delegate who has joined this finale of ADA Connect initiative. In fact, I just mentioned there was about 972 delegates who have joined across the country. And my sincere thanks to our CEO, Mr. Ajay Dhiman, and management team at Acumentis, and all my colleagues from both sales and marketing who have made this program very much possible, sir. So thank you once again. Thank you once again, sir. Yeah.
Thank you.
Bye.